Good evening, everyone. Welcome to First Aid AMC MCQ. I'm Dr. Arshan Ahmed, and nice to meet all of you. And I can see a lot of you are already joined in our trial session today, and we're very excited to have all of you here. Now, I'm sure that all of you know about First Aid AMC, and that's why you are here to learn about how you can pass your AMC exam in the fastest possible time. Now, First Aid AMC is very, very well known in Australia, especially as part of the online Australian course to pass AMC MCQ clinical examination. And also, some of you will go for PESCI exam. So, for all of those exams that you might encounter to start working in Australia, will be covered by us. And every course that we provide has one of the highest rate of passing in Australia. And all of our doctors work in Australia, so we are very well oriented with the system. And especially, I have been working here for a long time. So the guideline, the updated guidelines, publications, everything, I'm very well oriented. So if there is any problem happens, especially when you start your preparation, you will find out there is a lot of confusion happens between John Murtagh and other Australian guideline. And then I will be able to help you in that regard. Because even though there are some guidelines out there, still we are not following that in Australia because some of them are just journals or publications which you are not supposed to follow for the exam. So only that is possible for someone who is actually working in here, not someone who never worked in Australia. So we have been helping the IMGs to pass these exams for the last 8 years. And throughout these 8 years, we have also updated ourselves every year in terms of AMC. AMC also has changed. Previously, there was a lot of things. Nowadays, they have changed how they're taking the exams. So we changed ourselves in relationship to them as well, so that you get the best preparation from us. So tonight, this class is mainly focused on on a psychiatry review session, which means you will get an idea that how we take one of our classes. But this is not the end of the trial class. So we are going to have 2 weeks free sessions with you. And the 2 weeks free sessions are starting from 10th of August. So just in few weeks' time. And a lot of you are already enrolled into the course and you are enjoying our portal, our software, and you have already started your preparation because we have uploaded a lot of notes and video recordings and you have already started your preparation. And that's really a smart way to start the course because you will be well aware of how we function, how we take classes, and you will be way ahead of a lot of others. But that's all right. It is not a competition. Every one of you will have your own way of preparation. And all you need to do is to make sure you give some time to prepare for this exam and then go for it. And with our course, you don't need anything else. We have everything that you need to pass this exam. So some of you are having trouble to hear. Is it for everyone? Like everyone can hear me, or is it someone who can't? Okay, let me just write for someone who can't hear. So you have to join from the audio to hear. Yeah, it's audible, right? Good. So in that case, and also if someone is my voice is good enough, like you can hear me clearly, there is no problem. Sometimes what we find that in Zoom, your computer or the Zoom might not have like enough volume in your end. So you might need to increase the volume of your computer. So that might be something, sometimes we find that out, or you might also want to just have a microphone, and that might sometimes help. Okay. So if there is anyone who is having trouble to hear me or having a trouble with the volume, in my end, I'm speaking very loudly. So even my neighbors might hear me. So sometimes it can be in your end also. Have a look that if your computer, the speaker is in a low volume or not. Okay. Perfect. So moving on. So as we are discussing about the first aid AMC, now many of you are might be like just a beginner and you don't have any idea about AMC or the pathway of registration. So if you don't know about the pathway of registration or how to actually like start your preparation, there is a class that we normally take where we discuss each and everything one by one, the step-by-step approach of AMC. Not just MCQ, your whole journey to become a doctor in Australia. So we take a registration kind of like a registration and pathway kind of review session, which mainly happens twice in a year. And usually we do it before starting a new course. So you will also get something like that. So wait for that class, which will happen in between the 2 weeks free sessions. And definitely there is a class to attend. Okay. But initially you will feel a little bit confused. You will feel like everyone is saying a different things. Everything is a bit of like confusing. And that's quite common. And everyone, like even when I prepared, I had the same issue. So there is nothing abnormal in that. And once you join the course with with all other people who will be also joining, and with our discussion and guideline, you will be fine within a month. Okay, so give it time, start learning with us, and that's more than enough for your preparation for now. So the course is not about just recall sessions or question solve sessions. The course is a blend between theory and the question solve. We don't just review questions, which is not a good idea at all, because many people just think that if you just do the questions and if you follow some of the Q bank, you'll pass this exam, which is bullshit, because you need a very good theory knowledge to actually answer questions in your exam, because those questions doesn't exactly come in exam. All right. So we make sure that you have a very good base. And based on those theory knowledge, you will be able to also answer questions. So I will discuss each and everything about the class after the end of our tonight's session. And then you can also ask me questions. I kept all of you mute for now, just because it becomes noisy when we take the class. But after we finish this class tonight, which might take 2 hours, we're going to discuss each and everything about the course. Okay, so let's start with how AMC exam is going to be. And then we will come to the course. Okay, because I don't care if you join my course or not, but I care if you learn something from this class. And that is more important than joining any course. Because if I can help a little bit, and if you remember me, that matters a lot. Okay, so let's move on. So MCQ exam, it's a computer adaptive software based exam, which means that this exam will be taken on a computer, and you can't do it online like AMC clinical exam. And that is an unfortunate thing. And I hope at some point AMC will do an online MCQ exam, which will be easier for you, because then you don't need to go to another country to appear the exam. So for AMC MCQ exam, there are 150 questions. And among those 150 questions, you get 130 questions, which are scored questions, and then you get 20 questions, which are non-scored or pilot questions. But unfortunately, no one knows which one is scored and which one is pilot. So every questions are important for you. But we know that the last 20 questions are always a scored question. So remember that the last 20 questions of your exam, so from 130 to 150, these questions always carry in like a high marks, and those are always scored questions. So why they do it? Because everyone usually like they get tired at the end of the exam, they run out of time. So those 20 questions carry a lot of marks in the exam. So make sure you know how to be good with the timing. So you get 3.5 hours to finish 150 questions. Now, in our course, we will give you an idea that how many, how much time you should keep for each question and how this usually works. And the portal that we provide you for your preparation, it has got like, I think at the moment, 60 or 70 mock exams. And those mock exams are all timed mock exam. And those are more or less similar to AMC exam. So you'll get enough idea to know how to prepare yourself and how to finish exam questions based on the times. Okay? So to pass AMC exam, you need 250 question, 250 mark out of 500. Now you might ask me that how they mark 150 questions as 500. No one knows. So they don't say how they mark the exam. That is a secret forever. But as you can see, to mark 150 questions as 500, some questions will be low mark, some questions will be high mark. So we get an idea that there are questions which might be just 2 mark, maybe 1 mark. Some questions might be 6 mark, 8 mark, or even 10 mark. But you don't know which one carries high mark. The one thing that they share is if a candidate, because this is a software-based exam, the software is designed in a way that if you get your first question right, and first question usually is an easy question. So you got your first question right. The software is designed to give you the next question is just a little bit difficult. So every time you are getting more difficult questions, the marks are also getting higher. Okay, and this just goes on and on. So let's say you got first question right. The software gave you another question which is a little bit difficult that also you got right. And then you came to fourth question, which was quite difficult. You got 8 mark. And then the next question, you got it wrong. So software again will start with giving you easy questions and it will just go around and around. Now, a lot of you, after finishing the exam, will say that my exam was very bad and it was very hard question. Now, remember that having a lot of easy questions in the exam means that you might haven't done well. Whereas if you get a lot of hard questions and you haven't got a lot of common recall questions, that means that you might have done really well in the exam. So don't get disheartened. Don't feel sad if your questions are hard in the exam. Okay. So this this is a bit of an idea about how software works in AMC, but they are very secretive in that case. So no one actually knows what happens there. So this is the AMC scale. Once you appear your exam, once you get your result, AMC result will look like this. So if you are above this 250 mark, you will pass your exam. Okay. Now, before we go into some of the subjects that you need to prepare for AMC, I want you to understand a little bit more about how the exam really works. Now, this is a MCQ. So there will always be 5 questions, like 1 questions with 5 options. And out of those 5 options, only 1 option is correct. So you don't have double answer. Okay, so let's say this is number 1 question. And this is your questions, and then you have got 5 options. Once you have chosen one option, there will be a next button. And then once you click on the next button, you will be able to go to the next question. Now, there is a few things to understand in here. If you are not sure about that question's answer, and you think, no, I'm not going to fill this now, I will do it later, that will not work. So you have to choose one option, and then only you can go to the next. Now, the problem is, once you choose an option, you can't go back, you can't change that answer anymore. So that is where the AMC has got changed over the last few years. Previously, you could go back and change. Even at the end, you can change. Nowadays, you can't change your answer once you click on the next button. But if you haven't clicked the next button, then you can change options if you like. But once you have clicked next button and you have gone to the next question, that the previous question's answer is done. Okay, so that is one thing that has been changed. Previously, you could flag a question in the software, and at the end, they would give you all the flagged questions for you to revisit and change the answer if you like. Nowadays, there is no flag option, so you can't flag it, you can't change it. Does it make sense for everyone that how that works? So in this way, you'll have to go from question 1 to question 150. Once you come to 150 question, there will be an option of submit. So you have to click submit, sorry. You have to click on the submit option or submit button. And once you click on the submit button, they will again pop up a question that, are you sure that you want to finish your exam? And you have to click yes button for your exam to be finished. As long as you don't do that, even if you have finished your exam, your result will come as withhold or failed. So this is a very tricky area because few of my candidates, and that was a long time ago, because nowadays I just discuss this from the first so that this doesn't happen. Initially, like long time ago when we started first, maybe 6 or 7 years ago, there was a candidate who actually did not know about it. And his or her answer, her result came as withhold. Okay. So this is one thing that I always say. I don't forget to say this ever because this is important, because you might have passed that exam if you just submit your answer. And that is quite unusual because the invigilator in the exam hall, they're quite helpful and they usually check that if you have submitted or not. But sometimes you can be unlucky, right? So you don't keep your fate on someone's hand. Rather, you make sure you do it right. All right. So few of you are asking about recording this class. You don't need to record it. I am already recording it and it will be provided. Okay. All right. So moving on. So this is your AMC MCQ, how the software works, how your exam will work. And in our portal, when you will also do those exams, the mock exams, you will get a good idea about what I've said. Okay, so nothing to be worried at all. Now, few other thing is, so normally we say that for AMC exam, you need some study partner. Okay. So the study partner is always going to help you with a lot of things. It's not just about solving questions with the study partner, but also you you get some mental support because you know that someone else is there who is also having the same thing. So always make sure that you are in a group. And if you don't have any group, don't worry, because in our course that you will find a lot of people who is also in the same same pathway and doing the same thing as you are doing. So you will be able to meet new people, make friends, and have a group of a study partner where you can also share your thoughts, solve some questions. We try to solve as much as questions as possible, but still, we always advise candidates to do a little bit of more by themselves as well. Okay. So what are the subjects that you need to prepare for? So the subjects that you need to prepare for are this. So you need to prepare for medicine, surgery, gynae and ops, pediatrics, psychiatry, population health, which is mainly covered under biostatistics. As you can see, medicine has the highest number of questions, but this is not the right percentage for a lot of candidates because the software doesn't do all the time in the exact same order. So many of you will get a lot of questions from medicine. Many of you might end up getting a lot of questions from psychiatry. Okay. So what we normally say that every subject is equally important except biostatistics, because biostatistics actually it is 12.5% questions that you would get. That means you normally get highest 3 or 4 questions in the exam, but all others, these are equally important for your exam, because you might think like I will just go through a lot of medicine and I will pass this exam. It doesn't work in that way, because there are people who get a lot of questions from mental health, a lot of questions from pediatrics. So all of these subjects are equally important. The good news is that you don't need to read pathology, biochemistry like USMLE. Okay. No, there is nothing like that, Dr. Fatima, that you have to correct 50% of each subject. So normally like you'll have to make sure that there are sometimes some mastery questions. Those mastery questions you can't miss. The mastery questions are like very common questions which come in every exam. And like the important ones, chest pain, myocardial infarction, prostate related questions, back pain related questions. So those are like daily questions. Everyone gets questions from those topics. So those are mastery questions. And now again, AMC never say which one is mastery questions, but we have found out through our experience that these questions always come in exam. So those must be the mastery questions. So those questions you need to get it right to pass the exam. Okay. All right. So lots of chit chat, but I hope these are important for you, and I hope this is helping you. But many of you might already know all of this, but some of you are not. So that's why we start with the initial part so that you know what you are starting. Okay, now moving on to psychiatry. So I will not scare you to death tonight. So we'll just go very slow and smoothly. And then gradually we will increase the flow of the topics that we discuss in the class. Okay. So first of all, this class is about psychiatry. The reason why we choose psychiatry as a trial class, because many of you never ever actually learned anything for psychiatry. And many of you are there like that. But Australia is a country where mental health is a very important and psychiatry is a very important subject here. So for both AMC, MCQ, and clinical, you'll need a good amount of knowledge from psychiatry. So it might look a little bit like complicated to you, but it will be easier day by day. So first of all, what are the books or research that you need to follow for psychiatry? So JM 8th edition is important. So this is our like main book that we will follow for any subject. Unfortunately, JM 8th edition doesn't have a lot of psychiatry topic, but some of the topic that it has, we will discuss it. Then there is very important is Kaplan Step to Psyche book. So most of you will need to go through this book because JM has more or less all the important topics, but Kaplan is well organized and it is easy to go through. But our notes mainly we will take note from John Murtagh and Kaplan Step to Psyche, and the note that we provide that usually has a combination from these two books. So you don't need to waste a lot of times reading these books. Okay. Some websites also you can follow for psychiatry. There is Range CP, Medscape, but we advise you to go through UWorld USMLE, which is very good. So we usually provide, so I would provide you all the books that you need. So all the PDF books will be provided anyway. So you'll get UWorld USMLE. That PDF, not everything, just the psychiatry part and the important topics that we discuss in the class, you should also go through from UWorld. So UWorld has questions and answers, and that gives a good amount of basic for psychiatry. So definitely it's a book to read. But your main guideline will be our lecture note, which has everything that you need. And then after we finish psychiatry, so psychiatry, we take 3 or 4 class. So today is just one class, and then in the course, you will get rest of the class. So after we finish psychiatry, we will also do a psychiatry question solve class. And that question solve class, we also finish at least 50 to 70 questions, and you will get a good idea about the questions that come in exam. Okay? So that's mainly your books that you need to prepare. Yes, so most of the time you need to read the notes, but sometimes because we can't just take everything from the book, so there are few topics that we don't include in the note. So those we normally go through in the class, that this part, just read it from John Murtagh. So very few are like that, but most of the things will be in the notes. And the exam will be held every month. So there is a like lot of dates to appear the exam. Okay, Dr. Danish. So every month there are exams. Okay. So we will answer those questions related to AMC at the end of the course, at the end of the class. Okay. But let's move on to psychiatry. So far everything is good. Are you guys with me? Are you understanding me quite well? Perfect. Moving on to our topic for tonight. So depression. Now don't get depressed because our first topic is depression, unfortunately. But depression is one of the important topic for psychiatry. So major depressive disorder. So a 70-year-old woman was recently admitted after her son informed the doctor that she had been doing very poorly over the last few months. The patient reports 30-pound weight loss, decreased concentration, feelings of helplessness, hopelessness, decreased energy, depressed mood, and decreased sleep. So there is a DSM-5 criteria that we normally follow to diagnose major depressive disorder, or in short, MDD. So MDD says there are 9 symptoms, and out of those 9 symptoms, if someone has 5 symptoms and it occurs almost every day for at least 2 weeks, that can be diagnosed as major depressive disorder. And number one and two, at least one of these two should be there. So number one is depressed mood, and number two is loss of interest, which is also called anhedonia. Okay, so this is the most important symptoms for diagnosing depression. So depressed mood, loss of interest, change in body weight or change in appetite, change in sleep, so having insomnia or hypersomnia, psychomotor agitation or retardation. So psychomotor retardation means patient who gets depressed, they get very mentally slowed down. So they get very slow, doesn't want to do anything. And then there are few patients who gets quite agitated. Then there is loss of energy. So they always feel very tired and fatigued, feeling worthless or having like a guilty feeling. Concentration can be impaired, and suicidal thoughts. Sometimes question ask you that they give you a patient with depression and they ask you that what is the most important question, or what is the most important symptom that you would look for this patient. So if they give you a patient who has depression, and the question is what is the most important thing that you would look for in this patient, that is always suicidal thought, because you don't want to miss a patient who is suicidal. Okay. So these are your 9 symptoms for depression. There is an easy way to remember this. This is called psychi caps under the mnemonic. So M for low mood, S for lack of sleep, I for loss of interest, G for guilty feeling or hopelessness, E for lack of energy, C for lack of concentration, A for lack of appetite, loss of weight, P for psychomotor retardation or agitation, and S for suicidal thoughts. So that's psychi caps. So if someone has got 5 out of 9 symptoms lasting for 2 weeks, then you can diagnose the patient as major depressive disorder. Okay. So the two criteria for major depressive disorder is depressed mood and loss of interest, otherwise known as anhedonia, has to persist for at least 2 weeks. So apart from major depressive disorder, there are some other name for depression. So there is a condition called persistent depressive disorder, or PDD. And PDD is someone who is having a long-standing depression but mild severity. So mild depression, patient is always depressed most of the time of the day, and it has lasted for at least 2 years. That patient will be called as having a persistent depressive disorder. On the other hand, major depressive disorder also, depending on how bad is their symptom, we can divide it as mild, moderate, and severe. We will come into that later on. Now, major depressive disorder sometimes can be associated with psychotic features, which means a patient who is severely depressed can also have features of hallucination, delusion. That means they're seeing things that no one else can see. They're hearing voices. So if a patient has got major depression, along with that, they have psychotic features, that has got the worst prognosis. So they ask you sometimes in the question that what is the worst prognostic factor in this patient? So they give you a patient who has major depression with psychotic feature. Major depressive disorder patient can have some atypical feature, like they can have increased appetite, increased weight, and increased sleep. Why it is called atypical? Because in most of the patient, depressed patient has lack of appetite, loss of weight, and lack of sleep. But some patient can be just a little bit different or opposite. So that's called atypical features. So first of all, we need to know who is diagnosed as major depressive disorder, what are the worst prognostic feature, what are the atypical feature, and then we come to the treatment. Before we go to the treatment, because treatment depends on the severity, let's talk a little bit about depression in children and adolescents. Now, although sadness, feeling low is very common in adult who has depression, children usually doesn't come as sad. Rather, they become more irritable and cranky when they are depressed. So don't look for sadness, crying, or low mood in depressed child or adolescent. But sometimes their depression can be manifested as irritability, feeling helpless, worthless, not going to the school, not talking to anyone. Okay, suddenly stopped going outside. So those can be a feature of depression in children. Okay, so you can see here, these patients, the children, they can have loss of interest in usual activities, irritable mood, and they said in children, irritability may be more prominent than sadness. Now, there is a question which comes in exam. What is the best antipsychiatric medication for a children or young adult? So we haven't talked about the medication yet, but we are just going into that. So if the question asks you, they give you a child who has most likely major depressive disorder, and the question asks you, what is the best antidepressant for a child? So what do you think is the best antidepressant for a child? Anyone? Very good, guys. So we normally would choose between fluvoxamine or fluoxetine. Okay, so fluoxetine or fluvoxamine, that's usually the best antipsychiatric for children, and that's under the group of SSRI. Good. Moving on. So there is a condition called recurrent brief depression. So recurrent brief depression is someone who is getting recurrent depression of short duration, lasting maybe up to 7 days, and it coming every month. So we know that to diagnose someone as major depressive disorder, the duration has to be at least 2 weeks, right? But if it is just lasting for a week and coming on and off, maybe sometimes every week or monthly, that is what we call as recurrent brief depression. For that group of patient, antidepressant doesn't work. So for them, you have to go for lithium as an alternative medication, and also sending the patient for psychologist who would go for cognitive behavioral therapy. We'll come into that, don't worry, what is CBT and psychotherapy. There is a seasonal affective disorder, which doesn't come in exam. So sometimes patient can have sadness or depression during the winter time. And other time, they are totally fine. So they are called having seasonal affective disorder. Okay, now the main thing, management. Management comes a lot in the exam. So first of all, if you suspect that a patient might have just a mild depression, then the treatment will be psychological therapy. So you send the patient to a psychologist And the psychologist will listen to the patient. They will try to convert their negative thinking to something positive. And that is what we call as cognitive behavioral therapy. So CBT is one of the best psychotherapy in almost all psychological conditions. And that is usually your answer in any terms of psychotherapy. Okay. So mild depression, psychological therapy. If it is moderate depression, you will again start with psychological therapy. And if it doesn't work, you can start antidepressant. But for severe depression, you have to start antidepressant as the first line treatment. And as an adjunct, you can continue the psychological therapy. Sometimes even if severe depression doesn't get better with maximum tolerated dose of multiple antidepressant and psychological therapy, you might need to even go for electroconvulsive therapy, which is ECT. That is the last resort for very severely depressed patient who has life-threatening complication. Okay, so how we know that someone having mild, moderate, or severe depression? It is a tricky area. There is no specific scoring system or guideline to know who is having mild, who is having severe, but the question will give you an idea. Like, let's say someone having bit of anxious mood, not going to work, feeling a bit of sad, but sleeping well, and then they they're not having lots of appetite. So they just feel fulfill the criteria, but it's not affecting their life a lot. That is mild. Severe is something which is affecting their life. Like patient has stopped going outside, patient having suicidal thought. That's severe. So in between this mild and moderate, that will be mild and severe, that will be moderate. Okay. So basically, they give you questions in a way so that you know that if this patient having mild or severe depression. All right. So severe depression is usually they have suicidal thought. So suicidal thought is one of the most important thing to diagnose severe depression. So in case there is severe depression, your choice of management will be antidepressant. Okay. Now let's go through this question a little bit to understand how exam questions can come there. So a 72-year-old man comes to the office due to worsening depression and insomnia since his wife died 7 months ago. The patient experienced lethargy and episodes of tearfulness. He has little interest in socializing with his married friends. So lack of interest, then lethargy, tearful, insomnia. So already you can see 1, 2, 3, 4. He has attended 3 sessions of supported psychotherapy and expressed appreciation for the referral. However, patient continues to feel depressed, experiencing severe insomnia. He's feeling very guilty about her death. Patient experienced a moment of severe depression last week in which there was a brief thought of suicide. And also patient lost weight. Which of the following is most appropriate next step in the management of this patient? Now, my question to you is it mild, moderate, or severe depression? It is a severe depression, right? Because of the suicidal thought and how they're saying it is getting worse. So for this patient, only psychotherapy is not enough. So you will need to start this patient with the antidepressant. As part of antidepressant, we have, now I will come back to that question. We have mainly SSRI. So SSRI is the commonest antidepressant that we use. And as part of the SSRI, we have fluoxetine, citalopram, scitolopram, sertraline, paroxetine, and fluvoxamine. all of these are commonly used in Australia. Now, there is some others, like there are some newer antidepressant, which is metazapine, which is not a SSRI, and there is SNRI, and under SNRI, we have got venlafaxine and desvenlafaxine. So these are the three common groups. And then after that, we have got tricyclic antidepressant, which is your amitriptyline, nortriptyline. So if we give you a good idea about antidepressant, the first line is SSRI or SNRI. So SSRI is those common ones. So citalopram, escitalopram, fluoxetine. Then SNRI is venlafaxine, desvenlafaxine. Then we have got metazapine. And then we have got tricyclic antidepressant, which is not the first line anymore. Now, coming back to this question, so you want to start this patient with the antidepressant, right? So what would you do? Number A is increase the frequency of psychotherapy session. No, that's not enough. Prescribe amitriptyline. So amitriptyline is tricyclic antidepressant, so it can be a viable option. So let's skip it. Prescribe metazapine and continue psychotherapy. We know this is a newer antidepressant and commonly used. So yes, this is another option. Prescribe zolpidem for insomnia. Zolpidem is a newer antidepressant, newer benzodiazepine for insomnia. We don't use benzodiazepine in a depressed patient just because they are having sleeping problem. So benzodiazepine is never, like almost never answer to your question in the exam. It is very strictly given in Australia. So try not to choose benzodiazepine in your exam question unless it is really needed. So that's gone. Provide reassurance and continue psychotherapy. No, that's not the only thing that you do. And go for ECT. You can't just jump to ECT before trying an antidepressant. So that's also not the right option at the moment. And always remember, in the exam question, you will see this kind of question. What is your most appropriate next step? Most appropriate next means what is your next management, not the best. Okay, so the next step is giving an antidepressant between B and C. So which one you would choose, B or C? Yeah, so most of you want to choose C, and that is right. So you will choose C. Now, good thing about C is that metazapine can also help with insomnia because it can be a bit sedative antidepressant. Okay, so this is a good medication, and also we we try not to give amitriptyline in an elderly patient because of its anticholinergic effect, because it can cause urinary retention. It can even sometimes cause delirium in this patient. So we try not to give amitriptyline or TCA in a very elderly patient. So on the basis of all of those, C is our right option. So you have done well. Very good, guys. Now, what are the common side effects of this SSRI? So SSRI, the most commonly it can cause, like some of them can cause appetite problem, nausea, tummy upset, dry mouth, headache. Sexual dysfunction is not uncommon. So these are usual side effects, but most of the patient, they get this side effect for the initial 2 weeks, and after that, their body get adjusted with this. But some don't. Some get severe side effect. Now, if you look on this, this is our common SSRI that we use. And although pharmacology is not your topic for exam, but there is a lot of questions which come from pharmacology, especially drug side effect and drug-drug interaction. So throughout the course, I will discuss the important medication side effect and interaction, and that will be enough for your exam. So most of the SSRI, they give you GIT upset, Some of them cause insomnia. They can increase the anxiety, drowsiness. So these are common. But the common questions that come in exam is two of the important things. So one, SSRI, very commonly they causes GIT upset, and SSRI, very commonly they causes sexual dysfunction. And the question sometimes come from this. So first is SSRI causing GIT upset. Let's say this is also your AMC handbook question. So AMC handbook question, the question was something like this. So you have started a patient with sertraline, and you have started the patient with, let's say, 100 milligram sertraline or Zoloft, and the patient started to get severe tummy upset, so diarrhea, abdominal discomfort, nausea. Okay, you have reduced the dose to 50 milligram, and still the symptoms are ongoing. What will you do next? So sertraline usually comes as 100 milligram or 50 milligram. So if you are giving 100, you can definitely try reducing the dose to 50 milligram if patient is well controlled with the depression. Now, even after reducing the dose, still symptom is persisting and patient is not tolerating the side effect, your option would be to change this sertraline to another group of SSRI. Okay, so you will change it to another group of SSRI, which means you can change from sertraline to citalopram or escitalopram or fluoxetine. All right, so that means GIT upset, you can manage it with changing between SSRI. And how we change the SSRI, that also a different thing to understand. You can't just stop medication straight away. So you have to lower down the dose of the medication. So let's say you have given 100 milligrams sertraline, then 1 week patient will be taking 50 milligram. Next week patient will be taking half of 50 milligram, and then gradually stop it. And then sometimes we give a washout period in between two antidepressants. So we give 3 or 4 days of no medication at all, so that any drug that left in the body can get washed out. And then you start the new antidepressant. Okay, so that's how we change antidepressant. Gradually we wean it down and then restart. So for SSRI causing GIT side effect, you can change into another SSRI, but the problem is there. If you have got a patient who has been started with, let's say, sertraline 50 milligram, and the patient has tried 50 milligram for 4 to 6 weeks, and still patient having significant sexual dysfunction that the wife doesn't want to continue the marriage anymore. So what would you do at that time? You have to treat this patient because you can't just let the wife go for this. So the option in this case is, first of all, they say that you can just wait and watch, which mainly only occurs in 10% people. And that is not the best option because these patients actually having like a familial disruption because of this. So you can't just wait. Second, you can reduce the dose. Now, reduced dose only works like if a patient who is on 100 milligram sertraline and they're having a well-controlled depression, then you can reduce the dose to 50. But someone who is on 50 milligram, but still their depression is not well managed, then you can't reduce the dose because that will not work anyway. So reduction of dose is another way to see that if that works. It's still not working. The third option is to change it to a different group of antidepressant. So change it to different antidepressant, and those antidepressant you can choose from metazapine. So metazapine has less sexual dysfunction, and there are some newer ones like bupropion can be used. Okay, so that means changing to a different antidepressant, not change between SSRI, because almost every SSRI will have a sexual dysfunction. So changing in between SSRI doesn't work. The other option, if patient does not want to continue any antidepressant because patient is fed up, then you can add sildenafil or Viagra. Okay, so that's our step-by-step management of sexual dysfunction, which is associated with SSRI. Does it make sense for everyone? You guys are with me? Okay, so next is some other side effects. So metazapine also has side effects. So most commonly, it can cause severe sedation. So patient can become quite sleepy. It can make you constipated, drowsiness, increased serum cholesterol, weight gain, and increased appetite, dry mouth, decreased appetite. So it works in different way in different people, but mainly severe sedation is the common side effect. Then the side effect of SNRI. So that's the venlafaxine and desvenlafaxine. Venlafaxine, commonly known in Australia as Effexor, and it's a very commonly used medication. So the common side effect of venlafaxine is nausea, but this is one of the medication which is well known for causing insomnia. And this is one of the medication which can cause weight loss. So this is a good thing that most of the antidepressants, such as like all the SSRI, metazapine, they usually increase weight of the patient. And many patients, especially female patient, does not want to continue SSRI because of this side effect. So in those situations, you can change them into the venlafaxine. Okay, because this is one of the antidepressant which is known to cause weight loss or at least no weight gain. The serious side effects are it can cause hypertension. So it's very important not to give it in a patient who has uncontrolled hypertension. You can't give this medication in a patient who has seizure or epilepsy. And it can increase the suicidal thought initially, but that's not a contraindication to start this medication. So just because your patient having suicidal thought, it's not like that you can't start this medication. You can, but you need to follow up the patient more regularly to make sure the patient is all right. So these are the common side effects of SSRI. Now there is a very serious side effect of SSRI, which is called serotonin syndrome. So serotonin syndrome, it is rare, but just last week, I've got a patient who had a serotonin syndrome. So it is not that rare. So while rare, it is a serious adverse reaction to the use of SSRI and other serotonergic medication. Now you know that SSRI increase serotonin in the brain or in the blood. So if a patient suddenly increased the dose of the existing SSRI, or somehow patient taking multiple SSRI, maybe he went to one doctor, he has given citalopram, and he went to another doctor, and next doctor gave fluoxetine. So now the patient taking two SSRI, so that can cause increased serotonin, causing the serotonin syndrome. Apart from serotonin, like SSRI, there are other medications which can also increase serotonin in the blood, like opioids, stimulant drug like the illicit drugs, street drugs, antiemetics, lithium, selegiline. Even sometimes, like a very binge drinking of alcohol can increase the serotonin. So, very commonly we see tramadol and SSRI together causing the serotonin syndrome. So how this patient will come to you? So patient definitely with the history, you will find out that he is on multiple SSRI or multiple serotonergic drugs, and they come to you with mental status change. So they can get confused, agitated. They can even get seizure or convulsion. They can get altered muscle tone, such as tremor, shivering, hyperreflexia, autonomic instability causing hypertension or hypotension, tachycardia, fever, and diarrhea. So mostly their adrenergic stimulation gets higher. So they get tachycardia, hypertension, tremor, pyrexia, diarrhea. So all the body starts to get hyperactive. That's how you can remember. And this is how they will look like. So you can see patient will be agitated. Their pupil will become dilated, so mydriasis. They will become sweaty, tachycardia, hypertensive, increased bowel motion like diarrhea. You can get tremor, hyperreflexia, and clonus. So when you get all of this, then you can suspect serotonin syndrome. And when you suspect it, your next step of management is to stop the medication straight away, stop anything the patient taking which can increase the serotonin. Now, you might think that we are supposed to gradually wean the dose, but that doesn't apply in here. You can stop the SSRI or any serotonergic drug immediately. So the offending agents should be withdrawn immediately, and then supportive medication can be started. So if patient having hypotension, you might need to give them fluids. If patient having fever, you need to give them cool blanket and paracetamol. So just symptomatic management. Okay. Now, sometimes serotonin syndrome can be confused with another condition called neuroleptic malignant syndrome. So we'll discuss that later on. So serotonin syndrome happens because of SSRI, whereas neuroleptic malignant syndrome happens because of antipsychiatric medication. So the difference between these two is serotonin becomes very abrupt onset and neuroleptic is gradual. And most importantly, serotonin syndrome patient gets tremor and myoclonus, like the muscle gets kind of like an abnormal movement. But in NMS, patient gets diffuse rigidity of the muscle. And very important finding is pupil. You know the serotonin syndrome, patient's pupil will be dilated, but it will be normal in NMS. Reflex will be increased and decreased in this NMS. Okay, so that's how we differentiate between these two. Now, definitely when we discuss schizophrenia, we will come into this neuroleptic malignant syndrome again. Okay. Now, continuing treatment, like let's say that you have started antidepressant in a patient, how long you will continue that medication? We say that if patient has been diagnosed for the first time, it is recommended to continue the antidepressant for minimum of 12 months. And if it is a subsequent or relapsed patient, then at least 2 to 3 years. 2 to 3 years in JAM, but in some other guideline, they say 3 to 5 years. Okay. So that's mainly all about depression. So I hope you are not depressed after having all of this in one go. But as you can see, a single topic can have a lot to learn. And that was the main basis of my discussion today, that everything that I have discussed, everything came in exam sometime. Okay. And these are quite important topic for your exam. So the class mainly, when we take it, we just don't just go through the theory, but we try to incorporate the questions with the theory so that you know what is coming in the exam and what is important for the exam. Okay. Now, because sometimes things can get quite boring if we just continue talking and talking. So I will take a break of 5 minutes, but in between that, let me discuss a little bit about the course, and then we can also restart again after that. Okay, how that sounds? Does it sounds like that's good? And you can ask questions and everything. Yeah, let's do that. So what we are going to discuss at the moment is how the course is going to like how we are going to run the course, and we are going to also go through like what are the important things that you need to start with, and what will be the step by step like way to start preparing with us. So let me just open few things so that I can describe. Just let me stop sharing. I hope you can see the screen now. Okay, so let me explain how the course is going to be run, and then we can start. Okay, so first aid AMC MCQ course, this is a highly recommended course for any IMGs who is preparing for AMC MCQ. The new batch is going to be starting from 10th of August, and from that time, we are starting the 2 weeks free session as well. So everyone can join those 2 week session, and the classes, the schedules of those free sessions will be provided into the Facebook group. Now, running batch is almost finished, so there is no need to join the running batch at the moment, because I keep getting messages and email from a lot of you that can I join the running batch? I would strongly say that please don't do that, because we are almost at the finishing of that course, and all you would get is recorded session, which is not beneficial for you. On the other hand, what you can do is that you can join the course now, which is going to start from 10th of August, and then get added into our portal, because we have already added a lot of things in the portal. So you have lots of notes, lots of video recording of the running batch. So we are giving that. So rather than joining to the previous batch, just join this batch and get into those recorded classes if you want to start straight away. And that is best. Okay. So the trial class is happening today, as you know. Now, what we normally discuss in this course? So this is a 5 months course, but anyone can finish the course within 1 or 2 months if they like. How so? Because once the course will start from 10th of August, the portal will be having every recorded classes that has been taken in the last batch. So the last batch and your batch will be pretty much same, except the question solved will be a bit different. So in that way, what you can do is that if you want to finish the course in 1 to 2 months, you can go through those recorded classes. And if you give a lot of time, you can finish it in 1 or 2 months. That's totally fine. Okay, so that is one of the way to do so. So we discuss full theory when our portal will have 5 year sample questions discussions. So from 2018 to 2024. And in the software or the portal, you get mock exams, you get QBank, access to the course note until you pass the exam, and you get recorded session. That means the recordings will be there after each session. So all classes are live classes like this. And after the live class, you get recording, ideally after 1 or 2 days of the course, of the class, sorry. And the recording will be there until 10 months of starting of the course. So there is extended video recording even after finishing the course. Okay. And if you are a member of ICGP ACROM, you can also get some CPD hours from my class. The course fee is $499 Australian dollar plus 10% GST and admin fee, which will be about 548 Australian dollar. As I discussed, the duration is 5 months. We take class definitely 3 days a week. So the classes are designed in this way. So you get 2 theory sessions with me and at least 1 question solve class in a week. But some week you get 2 question solve classes as well. So some week you get 4 days a week and some week you get 3 days a week class, which is like a lot. Previously, we did not do like this. So we used to take like 2 to 3 days a week. Nowadays, we have increased at least 1 or 2 more classes every week. Okay, so definitely that is one of the reasons why we had to add the 10% admin fee, because there is a lot that we need to provide to these mentors, to the admins. So, and also we provide a lot of tax. So just to make sure that we can continue teaching the IMJs and we can survive, and also the time that we are giving that is well managed, that was the main reason. So I hope it explains your questions. The classes are mainly that we take on Friday, Saturday, and Tuesday. But sometimes the another extra class can happen any day, but you get schedules before. So 1 to 2 classes every week on recent question solve, which is must to do. Okay. Class time. So nowadays we are taking 7:30 to 9:30 p.m. Sydney time class, but sometimes when the daylight saving happens, so daylight saving will start from October, then the classes will start from 8:30, but it will be discussed in the course. So we will mainly cover definitely complete theory based on all the guidelines. So JM8, Kaplan Step 2, some other like ETG up-to-date guideline. Theory-based discussion. So just like the psychiatry we are doing right now, all the theory will be separately discussed. Like even for medicine, we divide the classes as cardiology, respiratory, like all the important topics that you need. After each theory session, we also do a theory-based question solve class. Like we finish psychiatry, and then we do a psychiatry question solve class. And then you will also need to do a mock exam based on that theory in our portal. Then 1 or 2 days of question solve class that you get with us in a week, that will be mainly focused on recent question solve. And that we have like a very, very highly recommended, very well-known mentors who mainly do those. And you will get classes from them in the free 2-week session to learn how they take the classes. But definitely we can't finish 5-year samples questions. So a lot of things are already given in the portal, but we mainly focus on 2024, which will be taken mainly on the live sessions. After you do the question solve class, you also monthly we update mock test in the portal, and then you need to also appear those monthly mock tests. So this is our software-based mock exam. So you get theory mock test, you get sample question, which means that question related monthly mock test, and also you get full 150 question mock test, which is exactly like you can say like 80% similar to your AMC exam. So that will be very, very important thing. So currently we are adding more and more 150 questions, but definitely this is something that will give you a good idea that how exam will be. But we always advise you to appear this mock exam before your exam, not at the start. So you get a Q bank. We also take extra classes on ECG, CAT scan, X-ray, CTG, stat, ethics, fundoscopy, ABG, and lots of other extra topics that we normally discuss anyway. We talked about the recordings and notes. You will get all the soft copy of all the books that you need. And sometimes nowadays, we also try to do a meeting with our candidates so that they understand, like if they're having any problem they're having with the course. So we try to make sure that they are well oriented. Again, we talked about if you don't have 5 months time before your exam, you can easily finish the course within 1 or 2 months by going through the previous batch recorded classes. Okay. And this is our website and this is our email. So if you want to enroll, I would advise you either you can inbox me through the messenger. So all of you know my ID in the Facebook group, just send a message. Or you can send an email to this first aid AMC 4536@outlook.com. And if you go to our website, firstaidamc.com, then you will also get to know all the things that we discussed. So this course details and everything is there. All right. So that's mostly all about our course and everything. Do you guys have any questions with the course for now? Okay, Dr. Asma, you can join the course for any month that you want, but the course will run for 5 months. Okay, and anyone join our course, it is same for like whatever time period you join. If you want to join for 2 months, it is up to you, but the course fee will remain the same, and you will be joining the same thing. You will be getting the same thing as any other course student will be getting. Now, if you're waiting for the admin approval to access the portal, just let us know. Currently, it is taking a bit of time because a lot of students are joining. So we advise that sometimes even it can take 5 to 7 days to get the access. Okay. So CPD is mainly for someone who is not working as a doctor in Australia or anywhere. So CPD is only needed when you are not working. So if you are in Australia and you are not working, then you can like think about CPD. But if you are in overseas, definitely you are working, you don't need to worry about the CPD. So any country that you are from, Dr. Das and Dr. Priyamani, we will send you an invoice once you either you send an email or maybe contact with me by messenger. Once you send an email and once we send you an invoice, you can pay it by online. So most of the time with your credit card, you should be able to make the payment. So that's fine. You don't need a AMC number to join this course. Okay, Dr. Tamanna? And you only will get the AMC number after you have done your EPIC verification and all other things, which we will discuss in the course. Excuse me. So if you don't have a AMC number, just let us know. And you don't need that to join the course. There is no payment option with Afterpay. Okay, so no after pay, Dr. Sabir. Do you take session during exam week recalls? So normally it's we take sessions every week. So it's not just like we'll be just taking during the exam week, but the classes that we take, that's more than enough for you to go for the exam. And our mentors, they finish question solve based on the month. So any month you are going for exam, those questions will be discussed in the course anyway. So there is no separate classes needed because our mentors are pretty ahead with that. That's a good question. So how much time you need to prepare for this exam? In in my whole 8 years experience, I have seen that those who go very fast, they usually struggle. So 3 months is not enough to prepare for this exam. Okay. So I would definitely say that because most of you are working somewhere and you have a lot of commitments, please don't rush into appearing the exam because you need to have a very good theory knowledge. You need to go through those question solve. At least we say at least go for 12 months question solve and then go for the exam. Okay. So ideally 6 months is best. And if you are doing a lot of work and you don't have much time, then wait for 8 months. So 6 to 8 months preparation is usually needed. And if you are really giving a lot of times to our course and finishing everything as we are doing, then take at least 1 month after the course finished to revise everything, and then you can appear the exam. Yes, so all the recorded sessions will be there. So every class will be recorded. Dr. Ali, theory, question solved. So yes, you will get everything. Yeah, you don't need EPIC verification to join the course. So it's not must to do. Just let us know. So CPD is mainly for someone who doesn't work. So for MCQ student, we don't usually ask you to get bothered with CPD. Excuse me. It's mainly important for clinical candidates. But again, if you are looking for a job after passing AMC MCQ, then CPD might be helpful, especially if you are not having recency of practice. So recency means that if you're not working currently in anywhere as a doctor, then CPD is important. And you have to be a member of the RACGP or ACRAM, and then you can add our classes to get the CPD. And that's right, Dr. Raj. So if you're not working, then having some CPD hours will be a very good thing to have. So Dr. Danish, you need both Epic account and AMC portfolio. And we will discuss about CPD a bit. Now, tonight class is not about CPD, guys. So let's not go into a different area. We will discuss about CPD in our pathway class and also more about this in the course, like how to add our classes and everything, but not today. But just remember, CPD is for someone who is not currently working as a doctor. You don't need to buy anything. This course is more than enough. So no need of buying any QBank also. So everything will be provided. We don't recommend any course for exam week recalls. The Dr. Dina, yes, you should go for some CPD hour. That will be good. How many hours per day we need to study? Very difficult to say because the thing is that no one can give you a specific hours. Excuse me, guys. So some can have very good and fast memory. Some can be very slow learner, but both of them are equally effective. So it totally depends how you do. But at least, like if you can give at least 6 hours a day, that is really good if you can. No, you don't need to book your exam date now. You can book your exam like few months before your exam. So it's not needed that you just start the course and then book for an exam date. Dr. Rana, 8-year gap. Yeah, we have seen people or doctors who has a long gap, but still they start working, so that's fine. It is enough if you follow our notes and our guideline. That's all that you would need. EPIC verification will be discussed in the orientation class. What do you mean by credit score, Dr. Sandra? I have never heard about credit score for AMC. You don't need to buy additional Q bank. No, if you take break from work for 6 months, it will not be considered as a recency of practice. Again, guys, these questions, if you can ask me during our pathway class, that will be really helpful so that we can go along with this class today. You don't need to pass English test. Very good question, Dr. Tanjina. So you don't need to pass English for any of the AMC exam. Only time you need English that when you start applying for job. It is possible, that's right, Dr. Devi. It is possible to get job after AMC 1. So after AMC 1, if you also pass the English, then you'll be able to secure a job. And trust me that a lot of negative thinking, a lot of negative comments are there in the market that no, you can't get a job, but there is a lot of job available at the moment. So please don't think of that like AMC clinical is very hard. No one passed the exam. How can I like going to be a doctor in Australia? Please avoid those people who demotivate you. So people get a lot of jobs because like I know because in my course or in our course, we see a lot of students after passing part one or part two, they're getting job every day. So there are a lot of jobs available, especially it's still now Australia is taking a lot of IMGs. So don't worry about that. Okay. Dr. Fatima, only Amedex QBank will be enough. Yes. So you need English. Even if you have a PR, you need an English test for job. That's must. Dr. Suresh, I can't give you advice about the credit card. So you might need to talk with the bank about how much limit you need to keep. How can I do payment, Dr. Gihan? So payment will be given by, so we send you an invoice. So once we send you invoice, then you will be able to do the payment by online. So most of the time, either with your credit card, or if you have trouble with credit card, then you can go to the bank and do it. Now remember, all of you will need to pay for your AMC exam by your credit card. So you need something where you can have him like where how you can transact online. So either you can do it by someone who has a credit card or lives in Australia or any other overseas, and you can ask them to do it for you, but you will need some way to do it. Okay. Is it possible to get PR after 35 years? Now, this is a new thing that is started. So I'm not quite sure about this new part that after 35 years, if you can get a peer, it is mainly for like if I remember, if I'm not wrong, it is mainly for someone for the university and other profession. But I can't give you this as a like a best answer at the moment. So you might want to talk to a immigration lawyer about this PR part. An English test is nowadays people give PTE rather than OET, Dr. Asma. but you can go for any of them. Yes, so you get lecture note in the in our portal. OET is accepted. How we join the course for 3 months? You just ask our page, ask us. So there is no different 3 months course. This is the same course, which if you want, like it's not just for you. Everyone will have the same way, which means the 3 months is mainly for like if someone wants to go very fast. So you will get that opportunity because in our portal, when you join, we give you access to our last of our previously finished batch. So you can easily go through their recording and finish the course within even 1 or 2 months. Yeah, that's right, Dr. Shuraya. So that's what I have also heard that 35 years is for mainly university student, not for doctors, because they take doctors for from any age. IELTS is also enough, Dr. Priyamani. For getting job, anything is fine. They don't look for what you have passed. So as long as you qualify the English test from anywhere, it's fine. Okay, so nothing is really that doesn't matter. Like if you pass OET, IELTS, or PTA. All right, guys. So let me just take a 5 minute break, and then I will come back and we'll finish the rest of the psychiatry. Now, few of your questions are regarding like pathway. Keep these questions for our pathway class, and then we will discuss. Like Dr. Tanjina, Dr. Saba, we will discuss this thing. Okay. Thank you. 5 minute break, guys. All right, everyone, let's start again. Dr. Benish, passing percentage. So you need to get 250 out of 500 to pass this exam. Do they ask experience later? Yes, they do. So you need to show that you are working and everything. Internship to get a job? Yes, ideally you should have some kind of experience. It's not just like an internship. So basically they look for that if you have some at least few years of experience. Best is at least having a 2 years of experience in your country. But people get job even without any experience. So it is not impossible, but it is hard or difficult. Okay, moving on to bipolar disorder, which is our next topic. So we discussed about depression. Bipolar disorder is something like this. If you look on this graph, you can see that this is the normal mood of a patient. And sometimes they go into the depressive phase, and sometimes they get into the manic phase. So this manic phase is usually in combination with mania and depression together. We call it bipolar. So some patient can have mood swings. So sometimes they are depressed, sometimes they're in the plateau, and sometimes they're having euphoria and mania. So if someone has got this combination, then we call them as bipolar. So bipolar is a broad term to describe a recurrent illness with episodes of either mania or depression with return to normal function in between. So that means the patient always swings in between normal, low mood, and euphoric mood. So, what is the DSM criteria for a manic episode? So, you know the depression. Now, how you can diagnose mania? So, patient needs to have at least 1 week of abnormal, persistent, elevated mood. With that, three or more of the following feature. So they will have very highly inflated self-esteem or grandiosity, decreased need for sleep, very talkative and loud, pressured speech, racing of thoughts or flight of ideas, distractible, goal-directed activity, and excessive activity. And this will be really bad enough to cause marked impairment in their social, occupational, familial functioning. Okay, so at least 1 week of persistently elevated mood with three out of those seven symptoms causing marked impairment of their life. That is what we call as mania. There is a term called hypomania where patient has this symptom, but they are like a mild intensity and the symptoms persist for less than 7 days. So that's hypomania, and hypomania does not impair their functional life. Okay, so how we can remember these mania symptoms? So mania symptoms goes under this dig first. So dig first is D for distractible. So patient will be very distracted. So they will they will do multiple activities, not having focus in any specific job. I for insomnia, so they will say that I don't need to sleep. So they will be very excessively energetic, lack of sleep. They will have grandiosity, so that's for G. So inflated self-esteem. So they will think that they are above others. They will feel that they know everything, others don't know anything. Flight of ideas for F. So flight of ideas is kind of a racing thought. So patient is thinking about one topic. Next minute, he's talking about something else. Next minute, he's just talking about something else. So just talking and thinking different topics just within a very short span of time. That's flight of ideas. activities, so increased goal-directed activities. So someone who doesn't do anything, doesn't want to go to work, suddenly started going to multiple work. So they're talking about going for a let's say going to become a lawnmower, or the next minute he thinks that he's going to be a teacher, next minute he thinks that he's going to like invent something that will give him Nobel Prize. So increased goal directed activities suddenly out of nowhere, that's also a feature of mania. Pressured SHP, so they usually talk very fast, rapidly, and with a you'll know that they're very talkative. Thoughtlessness, they start taking more and more risk. So they start gambling, they start like investing in things that will just ruin or that will get bankrupt. They start going for unusual sexual intercourse with unknown people. So drive recklessly. So risk-taking behavior suddenly also another feature of mania. So if you have got a patient who has this kind of symptoms for at least a week and definitely impairing their functional life, that's the time we call it mania. Like in this patient, if you see, a 19-year-old college student is taken to the school counselor after he fails several classes. The patient is enrolled in numerous classes, most of which have conflicting times. His grades are poor, yet he is undisturbed by this. He has enrolled in numerous organizations such as chess club, drama club, student government, sports, and at least two other fraternities. Speech is pressured and has psychomotor agitation. So that's mania. Okay. So a mood disturbance in which patient typically experience symptoms of elevated mood for at least 1 week that cause significant impairment in their level of functioning. So there are bipolar 1 and bipolar 2 disorder. So bipolar 1 is someone who has got at least one fully fleshed manic episode. So mania plus depression is bipolar 1. Hypomania plus depression is bipolar 2 disorder. Okay. So bipolar 1 is mania plus depression, and bipolar 2 is mania, hypomania plus major depression. So we already talked about some of the features. You can go through that. Management. So management of acute mania comes in exam, very important. So acute mania is a medical emergency and it requires hospitalization. And even if the patient doesn't want to be admitted, you have to go for involuntary admission in this case. So you know about patient autonomy, that if a patient doesn't want to be admitted or treated, you can't force them to be treated, even if it is best for them. So, but there are some areas where even if patient doesn't permit, their consent doesn't matter, which means you can actually involuntarily admit that patient if that can be a risky thing for the patient or the other people. Like a mania patient doesn't have insight. They don't know which is good or bad. So they can cause harm to themselves or others. And they are, at that moment, they are not in the right state of mind. So in that case, even if they don't want to be admitted, that doesn't matter, you will admit them for their safety and other safety. So after you admit them, the treatment of choice is antipsychotic. So antipsychotic medication, so you can try risperidone or olanzapine. Among risperidone or olanzapine, commonly we use risperidone in Australia before trying olanzapine. Okay, so if you get both options in the exam, try the risperidone first and then olanzapine. And these are the common antipsychotics that we use. What are the second line? Like let's say someone who is manic started to assault your staff members or started to become very aggressive. Then definitely they will not take oral medication at that time, you can go for some IM medication such as haloperidol IM. Okay. Otherwise, second line, we have lithium, we have mood stabilizers such as sodium valproate, carbamazepine. If parenteral antipsychotic is required, haloperidol is the best. Okay. So that's your acute mania management. Antipsychotics are the most effective one. And in terms of antipsychotic, olanzapine or risperidone will be our first choice. And if both options are there, risperidone will be our first line. Prophylaxis. So we say that if someone gets 2 or more episodes of either mania or depression in the previous 4 years, that patient will be benefited to have a prophylactic maintenance treatment. And the best prophylactic medication for a bipolar patient is lithium. If lithium is not in the option, you can choose any of the second generation antipsychotic, and that's your olanzapine or risperidone. Or you can also choose any of these mood stabilizers, such as valproate, carbamazepine. Okay, so usually that's your answer in the exam for prophylactic. If you start a patient on lithium, you need to measure the lithium level in the blood because lithium toxicity is not uncommon. So what are the main lithium toxicity features? So lithium toxicity can present as tremor, muscle weakness, weight gain, hypothyroidism, renal failure, GIT upset. But we divide it into mild, moderate, severe. So mild is just tummy upset, nausea, vomiting, maybe a bit of hyperreflexia, tremor. Moderate is patients start to get hypertonia or hypotension. But severe is when they get cardiovascular collapse, seizure, or coma. Now, in mild cases of lithium, the main treatment will be IV hydration. So just start them with IV fluid. And that's usually the treatment. And for severe one, for severe lithium toxicity causing cardiovascular collapse, like patient is into shock, seizure, coma, or patient having renal failure because of lithium, for that case, you need to put them on dialysis. Sorry, dialysis will be the treatment for severe lithium toxicity. But mild to moderate, you can still try with the IV hydration and making sure patient is not a high dose of lithium. Not very important, so let's move on. For prophylaxis, it is only lithium. You don't need to continue antipsychotic. So antipsychotic is only during the acute manic phase during that time. And once that is better, you can stop it and put the patient on lithium as a long term. Now, very important topic for exam, management of bipolar depression. So remember one thing, that a depressed patient, if you give them antidepressant, they will start to get better. But what if that depression is just a feature of bipolar? Like this depression the patient having, maybe just a manifestation of bipolar disorder. If you give just antidepressant in a bipolar patient, then that antidepressant can precipitate a manic attack. So that's why we always make sure before we diagnose a patient as depression, we always make sure that they have never gotten episodes of mania or hypomania. Because if we just give antidepressant, the risk is there that it can precipitate a manic attack. So that's why if we have got a patient who has bipolar depression, the treatment will be an antidepressant plus a mood stabilizers. So you can choose any of these, lithium, valproate, carbamazepine, lamotrigine, olanzapine, any of these. And after 1 or 2 months, you will gradually stop the antidepressant and just continue these stabilizers. Okay, so the questions come from this topic. So if you have got a patient with bipolar depression, your treatment is a combination of both antidepressant plus a mood stabilizers. And then after 1 or 2 months, you stop the antidepressant and just continue the mood stabilizer. Now, this is your question to answer. A 27-year-old man is brought to the office by his wife due to her concern. Sorry, just the page gone missing. Due to her concern that he hasn't been himself for the last 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day, has no interest, no energy. The patient was hospitalized 6 months ago for an episode in which he became aggressive toward his wife. And at that time, he was staying all night, gambling away all their savings, investing a large sum of money in a startup company that became bankrupt. At that time, patient spoke very rapidly, was convinced that he had a brilliant plan to achieve world peace. He also experienced a similar episode 2 years ago. So what are these episodes? Those are mania, and now the patient having depression. So this is bipolar depression at the moment, right? So what is the most appropriate medication for this patient? What do you think? So most of you are with C. So let's see, this patient will need a antidepressant and the antipsychotic or any other mood stabilizer. So carbamazepine is a mood stabilizer, fluoxetine is an antidepressant. Okay, that's an option. Then we have got lithium and quetiapine. Both of them are for mania. Lithium sertraline. Sertraline is SSRI and lithium is mood stabilizer. So very good option. Lurasidone is antipsychotic, risperidone antipsychotic, not an option. Valproate clozapine, again mood stabilizers. Valproate haloperidol, mood stabilizers. So only option we have got is C and A. So which one would you choose? I would choose C because lithium is more commonly used for bipolar than carbamazepine. Okay, and definitely sertraline is there. So C will be better. Now this gives you an idea that in exam, always it will be two options that you will be confused. You can easily rule out most of the others, but most of the time, two options will be the most confusing one. And both of these options are correct, right? But you need to choose what's most commonly used in the exam and what is the most important ones. So in exam, that is the difficult part where they give you like a correct answer and you can choose any of them, but you need to choose the best one out of them. Okay. We talked about PDD, which is persistent depressive disorder, also known as dysthymia, which is mild depression persistent for at least 2 years. What is cyclothymic disorder? Cyclothymic disorder is someone who has got bipolar disorder lasting for 2 years. So it is a chronic disorder characterized by many episodes of depressed mood and many periods of hypomanic mode and lasting for at least 2 years. For this patient, you need to put them on lithium, okay, or any other mood stabilizers. Now, there is a term, and that also gets quite confusing in the exam, how to differentiate grief and depression, because the symptoms are quite similar. So depression patient will have same sadness, tearfulness, lack of appetite, So all of the symptoms will also have in grief or bereavement patient. But grief or bereavement usually happens after death of someone the patient usually loves or someone they know of. So that's usually important. Symptoms of grief will wax and wane. So it will sometimes get better, sometimes will get worse, but depression will be persistent. Shame and guilt less common in grief. In depression, it is more common. Suicidal thoughts are less. Now, the symptoms of grief can last up to 1 year. But we normally say that a normal grief should not persist for more than 6 months. When it persists for more than 6 months, it becomes complicated grief or complicated bereavement. Okay? And most of the patients, they usually return to baseline level of functioning within 2 months. For grief, only treatment is psychotherapy. But for depression, you might need to give them psychotherapy or even sometimes medication. So mainly the way to differentiate between grief and depression is, first of all, if a patient fulfills the criteria of major depressive disorder, like if a patient who lost someone and having all the symptoms of major depressive disorder, it will be diagnosed as major depressive disorder, not as grief. Okay, so grief patients does not fulfill the criteria of major depressive disorder. So they might have one, like 2 or 3 symptoms of depression, and that's it. But if they fulfill the criteria, that's even though they have lost someone, that will be termed as major depressive disorder. Okay, and other thing is that grief patient should get better, or at least level of functioning should get better within 2 months and should not persist for more than 6 months. Whereas depression can persist for years and years. Okay, so that's mainly the difference between these two. Now, we would not go into schizophrenia tonight. We will finish with this question, and the rest of the classes, when we do the psychiatry, we will finish schizophrenia and others. Excuse me, guys. So let's see. A 50-year-old woman is taken to the hospital after neighbors find her wandering the streets, mumbling to herself and gesturing. When approached, she begins to cry and express thoughts about hurting herself. Examination reveals a scratch mark on both her forearm and laceration on her throat. She reports feeling depressed since her husband died 5 months ago. She reports a decrease in concentration, feelings of helplessness, hopelessness, and hedonia. Quit her job, staying at home, and now she is also hearing her husband's voice asking her to join him. What is the next step of management? So next means what will be the next thing that you would do? Begin a trial of antidepressant, refer to psychiatry, refer for ECT, assess her thoughts about suicide, refer to outpatient department for follow-up. Remember, in here you have got that patient might be suicidal. And the first thing that you would assess is what's going on about this. So it could be a major depression, even though it looks like grief, but it could be major depression with psychotic features. But that's not our first thing. First thing is that we need to find out that if she's actually suicidal at the moment. So always in the exam, if there is an option of more assessment or getting more information somehow about something important, that is always our answer. Okay, so assess the thoughts about suicide first, and then management will differ based on that. If patient is suicidal at the moment, then yes, this patient will need to be admitted. Okay, so that's mainly the class for tonight. I hope you guys enjoyed the session. I hope that this at least starts your journey to become a doctor in Australia. And throughout the course, we will we will gradually increase the amount of topics, and then gradually you will be more and more stressed. But that is a good thing. Remember that if someone says that you just do 300 questions and you will pass this exam, that is wrong. You need to have time to prepare for this exam. And if you prepare what we are asking you to do, you will pass this exam without any doubt. Okay? But the thing is that I can't memorize things for you. You have to do your part. And if you do that, you will pass this exam with the research that we have. Okay? So we'll finish it here tonight. Now, if you guys have any questions regarding the course, which I think we have finished already, there will be enough time to ask more and more questions during our 2 weeks free session, which is starting from 10th August. We haven't provided the schedule for that yet, but it will be given to you this week on the Facebook group. So just keep an eye. And Dr. Sophia, you get access to everything in the portal until you pass the exam and the recorded videos for 10 months. Now, so we don't give these theory notes to anywhere except in our portal, Dr. Donna. So if you join the course, then you will also get access to the portal, and in the portal you get the notes and everything. So it's not about question that you need to pass in the exam. You need to get 250 in 500. And we discussed about that in the initial part of our today's class. So if you missed, then we'll post the recording of our today's class. So just go through the initial part. So UWorld USMLE will be provided in the course group, Dr. Devi. It is quite unusual, Dr. Jihan or Dr. Gihan it is. So if you are well prepared, you can pass in any month. There is lots of myth about February and June exam, but many times, like almost every year, we've seen lots of students who passed in February. So it is not actually the case. So your exam can be difficult in any month. But if you're well prepared, you can do it anytime. That's not a problem. And it is just a myth. You have 150 questions, not 100. And Dr. Urmi, the next class will be on 10th of August. It's not true, Doctor. Do not know what's your full name. It's showing as A. So it's not like you need to correct 100 questions to get to 50 mark. It is not that. It is not the case. So each question has different mark. So it doesn't depend on how many questions you are correcting. It mainly depends on how many marks you are getting. So some can get to 50 with less questions getting correct, because they're getting more marks from hard questions. So it totally depends. But there is no hard and fast rule about like correcting 100 questions. Okay. So course will be finished after 5 months. So just think, so if we start on August, so next year January it will be finishing. And normally we would try to finish it at the end of this year, but it depends how fast we can go. Yes, that's right. We do the recent question solves. So it depends. If you want to pay for the course now or at the end of the free class, doesn't matter. The My recommendation is if you want to join the course, make the payment, start the process, and get access into the portal. Because if you do it at the end of the free classes, you might need to wait for another week to do all of this because it takes time. So we send you invoice, you do the payment, and then we do the verification of your ID, and then there will be some email and you need to send to us, and then portal access can take 5 to 7 days. So it takes a bit of time because we're doing all of this for everyone. So in that case, I always advise if you want to wait for 2 weeks free session, that's fine. But if you don't want to wait, then just start the process. If you pass AMC, you will only be able to work in Australia. That's right, Dr. Sujit. And Dr. Nilodi, I think I have already answered your questions. I don't know why that matters. How can I get invoice? Direct message to Facebook. Um, Yes, you can do, you can either you can send a message to the Facebook in my messenger, or you can also send a email. You can start the Epic verification process. So we have already shared a PDF file in the Facebook course group that how to do the Epic verification. But once you join the course in our orientation session, we discuss a little bit about that. So after this course, I would suggest that you should go for the exam, which will be in, let's say March. So February or March next year will be you should plan for like appearing exam during the early months of the next year. That's right, Dr. Muhammad. So yes, we do like subject wise, we do the month wise, and then you can get the full exam pattern. So it has everything that usually needed. Okay, so and Dr. Shahangi, so the next class will be on 10th of August. Okay, all good, guys. So we'll be finishing it here tonight. Very nice to see a lot of you here, and hopefully, like with the free 2 week sessions, you will get to know a little bit more about this AMC. Okay, have a good night. Don't stress. It will be fine. Trust me. Take care, guys. Bye. Thank you.